Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the fourth and final episode of our mini-series, Psoriasis and Skin of Color Unplugged, supported by an educational grant from Janssen Scientific Affairs. Thank you for joining us for our fourth episode, featuring our host, Dr. Mona Shahriari, and her guest, the VP of Government Relations and Advocacy at the National Psoriasis Foundation, Jason Harris, as they discuss patient and disease advocacy for psoriasis patients with skin of color.
Hello, and thank you for tuning into Psoriasis and Skin of Color Unplugged. I'm your host, Mona Shahriari. I'm an assistant clinical professor of dermatology at Yale University and the associate director of clinical trials at CCD Research. And today I'm joined by Jason Harris. Jason, would you like to introduce yourself?
Sure. Thank you. Thank you, Doctor. My name is Jason Harris. I'm Vice President for Government Relations and Advocacy at the National Psoriasis Foundation. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected, and really excited to be here.
Thank you so much for joining us. So in our previous episodes, we've really focused on the clinician perspective. That's why I'm so excited to have you here, Jason, because you can help us understand the patient perspective when it comes to plaque psoriasis patient journey, especially in those individuals that have skin of color. So why don't we just dive right in, and why don't you tell me a little bit about your role at the NPF and what you guys are doing from an advocacy standpoint currently?
Absolutely. And I will agree with you. I'm certainly not going to bring the MD or PhD perspective, but a lot of our job within the advocacy team here at NPF is to understand what are the biggest challenges or issues that are facing our community. So we do a lot of outreach to our community, survey work, but also just talking to folks about like what's going on, what's happening. And I think the majority of our work focuses on access to care issues. So there are a number of them. New ones pop up every year, but things like prior authorization or step therapy, copay assistance issues. And then I think when we think about, different populations that are experiencing psoriasis, we know that although rates of psoriasis among Black, Hispanic, Asian individuals are estimated to be lower than white individuals, we also know that those with skin of color experience much higher rates of being undiagnosed, utilizing dermatologic care, and just in general, I think even though some of those estimates are lower, I think we understand that when we talk to people about their journey, that those things may be underestimated, due to a variety of reasons, whether it's diagnosis, access to, the proper physicians, different education, which I know we're going to dive into. And the last thing I would also note as I'm looking at some of our work is, when we think about a delay in diagnosis, that can be really, really critical in a negative way to someone experiencing flare-ups or things that end up being even more dangerous as we get into some of the co-occurring comorbid conditions that folks have. So excited to get into that.
Yeah, so I think, Jason, you hit the nail on the head in terms of a lot of the issues our patients with skin of color are currently facing. I know the last time you and I had a chance to chat, we had briefly talked about advertising campaigns for biologics, the presence of skin of color patients in public images, and sometimes these patients don't feel like the people in those ads or in those advertising campaigns look like them. How would you kind of add to that? Is that what our patients are truly feeling?
Yeah, I think, that's something I joined NPF about 2.5 years ago. And as a part of some work we do with the payer audience, we were able to get Dr. Junko Takeshita to come in and report on some of the research her and other colleagues did. And that's exactly what they found, that whether it was who actually is in the ad, what do those people look like? Do they reflect back into, the diversity of our community, and then even where the ads are being placed. So all those things, essentially, the research found that, some of the disparities that we see were mirrored in what the ads looked like and where they were placed. So, it's very clear that once properly diagnosed, folks with skin of color are less likely than white patients to receive, whether it's biologic treatment. And so, I think sometimes we think about how do we get that right care to people, and it needs to be reflected in all the things that are going out there. And that's something, we at NPF are really, really trying to work on in terms of, working with universities to make sure that in the education, there are correct pictures that reflect the diversity. I know I've also learned that, psoriasis looks different on different skin, right? And that's created, some hurdles and challenges for folks to get the right care.
Well, it's funny because in an era where everybody Googles their disease, if you Google psoriasis and don't see your skin tone or patients from your ethnic background represented, you're probably going to think that's not what you have. And if you go to your dermatologist or other healthcare professional and they tell you have psoriasis, you may doubt them. And we already know there's some degree of mistrust in the healthcare system, and really creating that inclusive healthcare environment is important. But I think that a big step would be just improving that overall diversity of the images our patients are seeing in pamphlets, on TV, so they're going to be more open to that potential conversation. Now, what efforts is the NPF really making to alleviate these concerns for our patients?
Yeah, so I spoke with a broad brush earlier, probably as we think about access to care type issues. We do, just to kind of reflect back some of those perspectives, we do an annual advocacy survey each year where we ask a number of different questions to folks. And I'm going to take us, when we think about social determinants of health or socioeconomic status, right, and what impact does that have? Folks, I'm just looking at some of the stats, right, but 62% of monthly out-of-pocket costs for some people, depending on copay assistance, is $50 or less. But that reflects back on who can get copay assistance. Can you get with the right doctor? Can you get with the right programs to ensure that you can get what is a high cost of care, but really critical for quality of life, as we've talked about. And when we think about folks that are in the $50,000 to $99,000 range of their income, about 50% of patients, maybe a little bit less, worried about having enough money to afford their treatments. And I think, there are so many reasons for why people worry about those things. And what we see is that folks a lot of times are worried about, they get a diagnosis, they get a treatment prescription, but then they can't get it. And there's a ton of reasons for why that is. And so for us, that's what my team focuses on, both in the state and federally, is how do we make those barriers less? Like, what are the things we can do to ensure that care is more efficient, and also that the people who need a treatment don't have to go through 3 different steps that maybe they've already proved this doesn't work. And so that they have the right thing, but they can't get it. And so that is, I would say, 75% of what we do. And we want to partner with everyone who has a stake in the game, if you will. And that goes to great physicians like yourself, but also, the payer audiences, to help them understand what is the patient journey, right? Like, what are your beneficiaries thinking about, experiencing? And, one of the things we always talk about is, a delay now, you're going to end up paying for it later. And so, those are really hard issues. The other, one other highlight I would say from MPF's perspective is we have a grant with the CDC under a program called the Chronic Disease Education and Awareness Program. And that grant is solely focused on educating primary care providers, right? So the person before they get to you, and educating on the impacts of psoriatic disease, that there are, it's not just a skin disease, it is a systemic disease, immune mediated. And there are a ton of implications if we aren't able to control and get this, get psoriatic disease under control. Things like cardiovascular disease, diabetes, mental health problems. There is a lot of suicide ideation in our community, some really high percentages. Most recently, I think at an NPF survey, had about 10% of folks close to it had some form of suicide ideation at some point. And when you think about that, that's really eye-opening when you think about psoriatic disease and the kind of the tumble and different impacts folks can have on their journey. So, I want to take a step back and think about how can we make it so that all of these issues are a little bit less. And I think ensuring that we can get easier, timely, more appropriate access to the right thing. I'm saying thing a little bit as a treatment, but there are a number of different treatments in this paradigm. It doesn't only have to be a biologic, but eventually we know folks are going to, end up needing potentially some of these really innovative and excellent treatments that have been out there. But it's how do you manage that care all the way through? And one thing I think education-wise that we need out there is that if you don't manage your psoriasis early on, there are a lot of impacts that can happen. And that's not only the 30% of folks that will develop psoriatic arthritis, but also some of the other ones I mentioned before that are huge cost drivers in our country.
Well, I think one comment you made that really resonated with me is that psoriasis is not skin deep, and all these comorbidities are something that a lot of our HCPs should be considering, in particular the primary care doctors, which a lot of times serve as that first gateway. And I know when I think of psoriasis, I think of it exactly the same way. It's a multidimensional burden of disease beyond what you can see. But the insurance companies, as well as what we currently have out there in this space, they categorize psoriasis into these cute little categories of mild, moderate, and severe, which is great if you're going just based on the objective criteria of the skin, but that subjectivity, that patient experience with the disease, the quality of life is not being included at all. And I think that's always been a challenge for us, because if you have 2% BSA and that BSA is on your face, that's kind of a big deal. I know that you guys are doing some efforts on a national level to help redefine how these insurance companies are looking at psoriasis, right?
Yeah. For everyone to understand that, as you mentioned currently, what the mild, moderate, severe classifications are, that, I will say when I first joined also surprised me in terms of how we think about, what is severe to someone. But obviously you have to figure out a way to do it. But when we think about what is the community's perspective, right? What do they consider severe? And I think what we found and our research team here at MPF has led this charge, partnering with the International Psoriasis Council as well. So it's national and international in this sense. Like you just mentioned, if someone has a lot of psoriasis on their face, but it only adds up to 2%, or think about, sensitive areas, different areas closer to your genitals, things like that, that is severe to that person. And so if we want to really have what everyone talks about as a patient-centered healthcare system, I think that the different ways that we provide or prescribe care needs to match up with what those perspectives are, what their goals are. So again, if you have to go into work and you have a lot of psoriasis on your face, what's the impact to your employer when you think about your own work productivity? Where's your mind going as you're trying to go into this meeting, and all the things you're having to think about beyond just, I've heard of the flakes too, right? Going onto your suit jacket or anything like that, wearing lighter colors. I think it gets really, really challenging. And I think that education for all of our partners out there needs to be really well understood. And that's why we're really excited to continue to push this research forward. But, it's a good example of how we've done a pretty good job, I think, over the last 10 years of working with the FDA and the FDA at large, of really helping to infuse the patient perspective into the drug development process. And that's continuing to get better. But I think where we want to start to see, that continuum grow is into this access to care space, right? So let's provide care based on what people need, what people want. Their perspectives may be different than some of the clinical classifications, or in some cases, like arbitrary classifications, quite frankly, from my seat. And I think there's a lot of learning to be had there, on top of also making this a more efficient system that in the end, I think will end up saving money. But I think we need to have a longer term horizon of how we're thinking about care and specifically in accessing it.
Well, and you brought this up earlier, the more we delay care, even in that person that has only 2 to 3% BSA, the ultimate result is that we're going to be hurting that patient in the long run, potentially more hospitalizations. A female with genital psoriasis, maybe she doesn't feel like she can be intimate with a partner. Maybe that leads to further mental health issues. And the entire cascade is just a vicious cycle that I think we have a really good way of intervening, as long as we keep the patient as our guiding light when it comes to making any and all of these decisions. Now, I know you'd mentioned earlier that sometimes when there are hiccups with respect to access or other elements that lead to a patient not getting their medication, they may or may not necessarily call their clinician to let them know. They just won't be on the medication. What have you heard on the NPF side from a patient perspective? What's going through their head when that happens?
Yeah. So when folks run into problems getting, the treatment that they were prescribed, I think it's really interesting to see what are the steps taken. So let's, give an example of, an individual receives a letter in the mail that says, they're going to have to try a different treatment than the one that was prescribed. Sometimes that will get back to your office, right? If you're able to take care of some of the step therapy and things like that, because they'll come to you and say like, hey, what's going on here? We also at MPF have a patient navigation center, which is part of our education team. That's, a hotline or an online chat, email to have anyone who has a question, they can ask it, and then if it's an access to care issue, sometimes that trickles to us, and then we can take a look. But I think there are other issues, whether the most notable would be more related to copay assistance. There are some programs out there called copay accumulators or copay maximizer programs that play around with how copay assistance money. So, right, it could be from a third party, that could be a manufacturer, that also could be just a nonprofit that helps folks get money to be able to pay for their care. And what we've seen over the last 6-7 years is that there are programs in place that will not count the copay assistance from a manufacturer or a third party towards a deductible. So essentially what happens is individual thinks they're all good, and then they end up going to the pharmacy counter and being told they owe, $2,000, whatever the number is. And there is a ton of data, not just with MPF, but just in general out there, that when someone has to, face a bill or an extra charge of even $200, they are, I think, way less likely to end up choosing care, right? So then we have people that are falling off and not getting the appropriate care. And as you mentioned, will end up in the hospital more, or just will be in the emergency room, all the things that we want to avoid as a healthcare system. But those types of issues, when you as a physician may not even know, just because you're not being told or you're not getting the full visibility into what that individual's journey is, it creates significant problems, because then again, you're going to come back 6 months later, whatever it is, and you're going to say, like, what's happened? And it might not be something they think of to go to you. Obviously, MPF, we want to be there as a resource for everyone. But it's hard to reach the 100% of the people out there living in our community that we'd like to. And so it is something that we think about every day, and quite frankly gives a lot of frustration when we start to hear more and more about it. And we have a nationwide of advocates out there in different states that are championing some bills and things like that. I will note a slight brag for MPF and the larger community, but we have about 36 states that have passed some form of step therapy legislation. On the copay assistance issue, we're close to 17, 18 states that have outright banned those types of programs. That doesn't get into the private insurance market, but I think that gives an understanding that, like, people are recognizing this is an issue. And we're also working federally to get both bills passed, because it's important to be able to cover a larger swath of the market.
And I think that's really important for us to understand what the problem is and have a plan to address it, because the future is bright, but we all know everything takes time and effort. So we appreciate everything you and your colleagues at the NPF are doing from that standpoint. And I also wonder, like, some of our latest and greatest medicines, these new drugs that have hit the space over the last 10, 15 years, this might be a big reason why some of our patients are unable to get access to them, especially those with skin of color. Because I always wonder, from a health literacy standpoint, just advocating for themselves standpoint, if you go to the pharmacy and get stuck with that even $200 bill and you don't call me and you never call me, I don't know that something went wrong. And now you're sitting there, unfortunately, suffering with your disease. But I guess the question is, as a clinician, what can we do to partner with the NPF and really help you guys in your efforts and help our patients that we may not be able to do in the trenches as we're seeing patients?
Yeah. So, as much free time as you have, we'd love to get you a part of our advocacy program. There are a ton of opportunities, both in potentially the state you're in, but also on a federal level. And I think the strongest partnership, the thing that we've seen be most successful, is when you have an individual from our community, someone living with psoriatic disease, partnered with a physician, an expert, a dermatologist like yourself, or rheumatologist for psoriatic arthritis, that can partner together to provide those different perspectives, right? Of here's the challenge on my side, and here's the challenge on the other side, and this is why we need X passed, or this is why we need this to be done. We need you to help us here. I'm just speaking to the legislators in this respect, but there is not a stronger partnership out there. And I will really add to the physician perspective is really, really critical. We partner with AAD. We like to partner with some of the state societies out there as well. But when we've seen success, it's really because of that partnership. And I'm speaking, NPF and our community, but also just think about all the other patient organizations, diseases out there. Those are the strongest partnerships because folks can really understand, again, closer to the full 360 view. And so I would say, our doors are open. We want to partner with everyone. We do partner with a number of great docs and folks, but there's not enough people or time to be able to fight back against a bunch of this. So if you are motivated or you're running into issues, we want to help, and we want to figure out a strategy to get some things done.
I think that's excellent. I've actually been a part of some of the days on the Hill that the NPF does. And it's really interesting because when we're sitting there testifying on behalf of various bills, it doesn't really help me in my bottom line in my practice. So I think it does go a long way with the legislators that are listening. But having that patient voice in addition to my voice, I've always found to be extremely helpful. So to all our listeners, if they're interested in advocacy, I think this is a great way to kind of give back and really help our patients have a chance at getting the medication that they need and deserve. Yeah. Do you ever partner with the Skin of Color Society?
Yeah. MPF has, I can recall being at a previous AAD meeting and chatting with some folks about how we could better partner, but there are so many different opportunities. And I will say, like, with our research team and some of the things that we're focusing on, we have like a Skin of Color, section on our website where we've looked at, again, some of the problems I mentioned before when we think about the delay in diagnosis. But there is a lot of great work out there. And we don't want to be duplicative. We want to be able to partner in the right ways and the smart ways to do that. And that is certainly an excellent group that's moving a lot of things forward.
And I guess we've talked about a lot going on in the gamut, but where do you think work still needs to be done? What does the future look like for the NPF efforts?
Yeah, well, there is, we'll see what Congress is up to as we head into post-election. There's a lot of things that will need to get done by the end of the year. So in terms of two of our priorities, which are related to step therapy and ensuring that there are some really good exemption processes, some things that are in place, like when do folks have to be told about the decision based, like a denial decision, right? So 24 to 72 hours, things like that. And then the same thing on the copay assistance issue. We want to make sure all copay assistance counts towards someone deductibles. I think when we think about different populations, that's going to cover so many different people and help so many different people. So the future is bright, I think. I think we've had a lot of movement recently, but it's still challenging to get something done federally. And I would just say that beyond the legislative front, there's a lot of things also regulatory wise, whether it's working with CMS, working with the FDA, that can be done. And then we are really motivated and will continue to work with payers to help them understand the impact of our disease. MPF has had a payer program for almost a decade that was led by our now CEO, Leah Howard. And she started it, but that's in my department's hands now. And I think those relationships are really important. And it's something that we need to continue because a lot of times payers can get a bad rap, right? A lot of people will only tell you when they have problems, but we really believe in partnership there. And I think that continuing that education, especially when we think about populations that traditionally have been, either it's underrepresented in clinical trials or just simply haven't gotten the appropriate care. Folks are motivated I think everyone's motivated to try and make a better impact in that space, but we need to come with the right data and the right experiences to help them understand that. I think of, someone who's had a lot of mistrust in the system, as you referenced before, if they run into utilization management, so some of these barriers to care, how are they going to see if they've gotten the right diagnosis finally, then they got, a treatment that them and their physician agreed on, and then they can't get it, right? It's kind of going to be the same old thing in a different way. And then those secondary, the cascade of effects, as you referenced earlier, I think need to be quantified better, but qualitatively, we know it's really hurting people and it's driving people away from getting, timely access to care. And that's just going to be bad for for everyone. But it's hard sometimes to help people think beyond that short-term period, which is what we're really dedicated to doing.
Well, I think the point that you made about us working together, no one person is bad here. It's about trying to educate the masses and ensure everyone understands, okay, these policies that were put in place, the intentions were good, but we had some unintended consequences. And now what do we do in terms of addressing that? Because I run a private practice and I put forth policies with the best intentions. And it's not until that policy has been around for a while that you realize, oh man, I didn't think about this. I didn't think about that. So I think it is important for us to all work together as a team.
There are a lot of unintended consequences out there based on decisions, and we can all help improve the system. I think sometimes we get stuck on defending, like, this is my idea, so it has to be the best. But that's a lot of what we see. Like, there can be some small improvements that will add up in a big way, and then there need to be some larger changes, that will hopefully transform how everyone's getting care. Like, there's so many new options now, whether it's technology or again, simply just having the right access. I know I'm going all over the place, but like, think about someone in a rural population that is 300 miles from someone. How are they getting the right care? And that's another area that we're trying to focus on, because, if you have to drive 3.5 hours to go see your dermatologist or your rheumatologist, it's a huge barrier. So whether it's, making sure that travel can be paid for, so someone can have, even though travel, that's still going to be a pretty high barrier, I would say. But how do we, again, make those things a little bit easier is something we need to focus on.
And how do we utilize technology, televisits, other ways of accessing clinicians that may not necessarily be close by? I feel like there's so much that we can still do, but keeping that patient as the compass when we're trying to make these decisions, I think really makes a huge difference.
Yeah, even someone who is stable, quote unquote stable, or that is progressing well, why do they have to come to the office if, generally speaking, they're okay and you have that, versus just saying, hey, checking in, wanted to make sure we can hit that prior authorization limit. But again, if they're not able to come, then they can't get the appropriate care. And technology, we always look at it. It should supplement, not supplant care, right? So it doesn't mean it replaces all the things that we need. If someone's, having trouble, they need to come in. You need to see them. You need to be able to look at the skin and not have it over a computer maybe. But there are a ton of areas or opportunities where we can make everyone's lives a little bit easier. And I think we're going to start to get there. We saw that, right, coming out of COVID with public health emergency and some of those things. So there are some learnings for folks to look at, and some data of how things went. But as most things come down to, it's who's getting paid or how much, and that's what we want to try and figure out, so everyone is feeling like they can survive and also provide the best care for folks.
And we can't become complacent. We got to keep trying to make things better and better. But Jason, it's been such an absolute pleasure chatting with you. I think we can go on for another hour if we had the time. But thanks for giving our patients a voice and really bringing their unique perspective and challenges to the forefront. And I can't thank you and the NPF enough for all your efforts on Capitol Hill to really help improve the lives of all of our patients with plaque psoriasis, no matter their background or skin tone. Do you have any final words of wisdom for our listeners?
Final words of wisdom. Well, first, thank you. This has been awesome, and appreciate the opportunity to speak with you. I think final words, I would say, I'm going to copy you a little bit, but it's not to be complacent. There are so many amazing opportunities, so much innovation that's been in this space that we are all grateful for, right? I've worked at different organizations where the disease population does not have a treatment. That's not the case here, but there are a lot of problems that folks have in order to get that right treatment or opportunity. So it's going to take everyone. It's going to take all of us really digging in to understand how we can best solve for these problems. And as we've mentioned the whole time, we're going to need to work together to do that on an advocacy level, on a policy level, but also on a research level, on an education level, on an awareness level, right, to ensure that folks are have the best opportunity to live the highest quality of life, which again, I think when we think about our population, our perspectives, that's what people want. And that's what they deserve.
I couldn't have said it better myself. Thank you for those final comments. And thank you to all our listeners for tuning in.
This concludes our mini-series, Psoriasis and Skin of Color Unplugged with Dr. Mona Shahriari. Thank you for listening. If you haven't yet listened to the other episodes in this series, be sure to tune in for some engaging expert conversations on all things psoriasis and skin of color.